Hello everyone, welcome to my channel Re-Revise. So if you're preparing for the Fmge December exam and you're looking for a consistent way to revise all the important stuff, the high yielding topics, the PYQs along with the PYTs, this might just help you out. So if you want to remember the way, you know how it is, right? If you want to remember the way, you got to walk through it again and again. Same goes for the concepts. You can't just learn once and expect yourself to get to remember it for a longer period of time. You need to revisit it, you need to re-revise for it to be registered in your mind, and I'm planning something regarding that. So before I explain the whole plan, let's just quickly warm up our brains a little bit. Let's learn a bit, and at the end of the session I'll tell you what I've planned, and if you're interested you can join my Telegram channel. And yes, this PDF will also be available there, so if you want to get this PDF, you can join my channel as well. So moving on, you have the Glasgow coma scale, and this is a very important topic, right? You definitely have one question on this and you can't mess it up, and we know everybody studies, so what we can do is we can learn it in a more efficient way, so we not just make a mistake but also save our time. So let's learn. We have eye opening, verbal response and motor response. How we'll remember is EVM, right? That is going to be 4, 5, 6. Alright, just in case you forget in the exam, remember V comes in between, so V will be 5 and IE is smaller, so that will be 4, and motor is going to be 6. Alright, so eye opening is going to be, how we're going to remember this is just two things you want to remember, right? So we'll remember it like a story. So you see a friend, he's unconscious, and you see him, the first thing you will do is yell his name, you'll call out his name. So first thing will be sound, and then you'll go and tap him, right? That will be pressure. Done. First one will be spontaneous, oriented, obeys commands, will be 4, 5, 6. This you need not remember. Next is going to be, like we said, we'll first call out the name, so sound will become 3, and then you're going to tap that person, it will become 2. None will become 1. Verbal response, now you can say viva, you can remember, but you'll get confused whether first you're getting confused, you're going to say some words or what it is. So for it to become a bit more simpler, remember confused is confused, fused it is, so it is number 4. Words, you can just, it can become 3. If you just flip W, it becomes 3, so this is 3. And S, it is second, so this will become 2, and none becomes 1. Alright, next you are having motor response. Motor response is going to be, see, in the exam you will have localizing to the pain, right? The patient is localizing to the pain. You can make out a word out of localizing, that is local. And how many letters does it have? 1, 2, 3, 4, 5. So 5 will be your localizing. Next is going to be normal flexion. Normal flexion is nothing but withdrawal, right? So in the withdrawal, how many letters can I can make out a word with, and how many letters does it have? 1, 2, 3, 4. So this is going to be withdrawal, normal flexion. Then you have abnormal flexion and extension. Extension, you can remember it as extension. So this is going to be 2. So what is left will be abnormal flexion. And in extension, the red nucleus is also affected. Alright, so that is it, and you're done with your Glasgow coma scale, and I hope you will not forget it. Let's see the score. Minimum is going to be 3, maximum is going to be 3, 5, 50. Alright, it's not 1, 0, no, it's 3 and 15. So mild will be 13 to 15, moderate will be 9 to 12, and then severe, we know it is 3, and 3 you can just make an 8 out of it. So this is sorted, it will be 8. So it is something like, it starts with 3 because 3 is minimum, 3, 5, 15 it is, so 3 to 8, this thing is sorted. Mild, M, you can just make a 3 out of it. So again, it is ending here 3, and the starting also you'll have a 3, so this will be 13 to 15. So what is left is moderate, 9 to 12. So it's mild is 13 to 15, severe will become 3 to 8, and then in between 9 to 12 is your moderate. And the GCS minus P is the pupil reactivity score. So both pupils are unreactive, you will do -2. If only one pupil, -1, and neither pupil is 0. So let's quickly revise this within 1 minute. So what do we have? Eye opening is 4, 5, 6. So it is going to be 4. First you will call out your friend, so it is going to be 3. Pressure will become 2, and none is 1. Verbal response, I don't have to make a story, it just fours, this will be 4. Words is you flip becomes 3, so this is 3. Sound is S, so this is 2, and none is 1. Next you are having motor response, so you can make a word out of it. Local will be 5 letters, withdrawal will be 4 letters, WITH. Abnormal flexion, extension I know it is 2, so flexion will become 3, and this is extension is nothing but decerebrate, that also we know it is decerebrate. So many E's in it, so that means this will become decorticate. Okay, so flexion, decorticate, decerebrate, and then we just saw the, and we'll not forget confused about this as well. So 3 you just have to complete, it becomes 8. Here also it's 3, mild also has a 3, so 13. So 15 is maximum, 15 to 13, and in between you have 9 to 12, and -2, -1, 0 is pupil reactivity score, and you're done with it. Let's move on to another topic here. This is also a bit confusing, so I'll make it easy. Okay, let's see. You have Rennie's test. Always remember in the exam, concept is, mnemonic is good, but concept is definitely important and must. You can, if you forget concept, mnemonic will be your additional thing, right? It's good you remember in mnemonic, but you can forget mnemonic, which is quite possible. Concept is something which will help you a lot in the exam, so you should have both. You can't miss out on anything. Okay, moving on, you have Rennie's test. Rennie's test, you know, normally air conduction is more than bone conduction. And how do we see? You put it on the mastoid, you place the tuning fork on the mastoid, that tells you a bone conduction, and then you put it in front of the ear, that tells you air conduction. And we know normally air conduction is more than bone conduction. It's in the alphabetical order as well, just in case we forget. Next we have Weber's test. Weber's test is purely seeing the bone conduction. You put the tuning fork on the middle of the forehead, and then you see which sound is heard better. Now you tell me air conduction, bone conduction, air conduction, bone conduction, and if I just mute this, then obviously I'll hear it better, right? And we mute this in the conductive hearing loss, right? That's why in conductive hearing loss the bone conduction will be better. Makes sense. Next is Schwabach's test. Here this one is you're comparing with the examiner's ear. The same thing you're doing in the absolute bone conduction as well. Then what is the difference? Here your tragus is not closed, which means your outer noise and air conduction does have a role in this, right? Here it is absolute, it's there in the name itself. So here your tragus will be closed, it's just bone conduction, and you're comparing with the examiner's ear. So this thing is also sorted. Now jelly's test, you're going to remember this as the jelly. You know how jelly will be like keep moving, wobbling. The same way, just remember there's something which is moving, that is your stapes foot, right? So the stapes foot, here in the conductive hearing loss, what happens is it will be fixed. So even if you apply pressure in the ear canal, there will be no sound changes, so it will be negative there. Okay, that's it. Now okay, with that this explanation is sorted. But in the exam, what if you don't remember the concept, you're like confused, what was what and everything? Let's just have a cheat code for it. That is going to be conductive hearing loss. From now we're going to call it chi. I'll tell you why. And then sensory neural hearing loss is the other one. Why it is chi? First thing, wherever it is negative, look at this, in Rennie's test negative, it is conductive hearing loss, chi again. Gell's test negative, conductive hearing loss, chi again, right? Wherever it's positive, you see positive has an S in it, so sensory neural hearing loss also has a S in it, so this will be positive here. Wherever it's positive, it is sensory neural hearing loss along with normal. And then in the Weber's also, it gets lateralized to the affected ear. Now we know the concept as well here. It's not that we are learning with no concept at all. We know why it is lateralizing to the affected ear, because there is no conductive hearing loss. We have muted it, so obviously it will be heard better in the affected ear, right? You only have bone conduction over there. There is no air conduction. The outer noise you have shut. So that is why here it is more, it is lateralizing to the affected ear. Here the problem is only bone conduction. The nerve is affected here, right? So you will not hear it in the affected ear, so it will get lateralized to the normal ear. But in the exam, just in case we forget, we also know it is chi. It goes to the affected ear only. जहाँ खराब हुआ है वहीं जा रहा है वापस. So that is why Weber's test is chi. Then we have Schwabach's. Schwabach's, remember, here the tragus nerve is not occluded, right? So you're going to remember both sensory and conductive pathway are being measured here. So can you see S and C both, right? So the same thing, wherever it is S, it is SNHL, so it shortened will be SNHL, here prolonged will be conductive hearing loss. Gels test, the same thing, negative will be conductive hearing loss, and we know the concept why as well. Gels test is negative because stapes is fixed, and here it will be positive, sound gets softer, stapes is mobile. Okay. Next, ABC test, normal or prolonged, will be again in conductive hearing loss. Wherever it is shortened, I know it is SNHL, so this becomes prolonged, this becomes the SNHL. Let's quickly revise what we have seen in this page. I saw Rinne's test, which is air conduction more than bone conduction. Then we have tested, first we're going to put it on the mastoid first and then in front of the ear. Then we saw the Weber's test, we are putting on the on the middle of the forehead of the skull or the skull, and where normally you will hear it equal in both the ears, and if it is CHL, we know it is chi, it is lateralizing to the affected ear, and if it is SNHL, it goes to the normal ear. Okay. In Rinne's test, positive, again wherever it is S, it is SNHL. So positive will be in SNHL, negative will be in the CHL. Normal or SNHL has positive. Next, Schwabach's, both the pathways are assessed, so the sensory and the conductive hearing loss, because the tragus is not closed, and we know why. Here you're going to remember shortened SS, SNHL will come, and if it is prolonged, it will be CHL. And why it is prolonged? Because you don't have AC, you don't have the outer noise in the conductive hearing loss. Gels test, you see for otosclerosis, it is fixed, so no change, it will be negative, positive in SNHL. ABC, absolute bone conduction test, which means you're placing the tuning fork on the mastoid and you're comparing with the bone conduction, the same thing, it will be shortened in SNHL, and it will be normal in the, or normal or prolonged in the bone conduction. Alright, next is your murmurs. Now this topic is very important because in the recent Fmge exam, there were 3 questions on murmurs, so I thought I will just include this as well. In murmurs, one thing, let's learn the concept first. Whenever I say systolic murmur or I say diastolic murmur, I am talking in terms of ventricle. We are not talking in terms of atria, right? So when I say systolic, it means blood is going in this direction, it is systolic. When I say diastolic, it is coming into the ventricle. Now let's apply some common sense. This is your left side of the heart and this is your right side, right? So on the left side, let's just see, we are talking about systolic murmur, which means these valves, the aortic valve and the AV valves, the mitral valve. So here you have the aortic valve, right? So when the blood is coming from this, imagine the blood is coming from this because it is systole. Now these valves are like your doors. If your door is narrow, you will have a murmur. So obviously whenever it is a systole, you will have stenosis, right? Stenosis will be there, and when you are having systole, a little bit of blood is going back, will go back, right, in regurgitation. That is called regurgitation murmurs, and you will have it in the systole. So when I say diastole, which means the blood is coming in, so in the diastole you will have mitral door will become leaner, will become narrower. So this will become mitral stenosis, you will see in the diastole. Now it makes sense, right? Look at this one. In the systolic murmur, you have aortic stenosis. Obviously, zahir si baat hai, this is your door and it has been narrowed here. It has become stenosed. So that is why you are having murmur, where the stenosis will be in the direction of the blood. The regurgitation will be in the opposite direction of the blood. Just remember this one. The flow of the blood is in the direction will be stenosis, opposite will be regurgitation, and now we know why. Now you don't have to get confused. Now it's pretty clear. So when you think of systolic, just sit, okay, there is blood coming, so the door must have been narrower, so aortic stenosis will come, mitral regurgitation will come, mitral valve prolapse will be there in the systolic, and tricuspid regurgitation, right, back side. So tricuspid regurgitation will be systolic murmurs. The same concept if I just apply for diastolic. So you are filling in the blood, so upar ka, now the door above the mitral and tricuspid valve, those should be stenosed, so you have mitral stenosis, and because it is coming diastole, the regurgitation will be aortic regurgitation, while filling will become aortic regurgitation, and then you have continuous murmur. And I'll tell you how to remember this. PDA, just remember patent ductus arteriosus is going to be continuous murmur. Also, if you have to know the logic, why it is continuous, because obviously this is a connection between both the aorta and the pulmonary artery, and we know no matter which phase it is, always the aortic pressure will be more than the pulmonary pressure. So that is why you have a continuous murmur, right? Okay, so that will be more in both systole and diastole. All right, so moving on, the first one, this was your concept. Now to remember the factual stuff, I'm going to tell you a mnemonic which is going to be a little funny, but trust me, it will help you in the exams. First one is going to be aortic stenosis. So if I just read, it is AS sounds like your ass, right? So we just to remember, to look at this, you can, that's how your ass is, right? As, so we're going to remember, this will be crescendo decrescendo murmur, right? In the systole, S1 to S2 is your systolic phase, and this will be crescendo decrescendo murmur. All right, and loudest it will be at the right second intercostal space. We all have two asses, right? So this will be right second intercostal space. So before that, let's just once go through this as well. So here you're having, this is going to be aortic, APET, right? So this is going to be your pulmonic area. That then comes your E, that is, I'll just write it this P, and then here it's E, Erb's point. Then you have the T, then you have APET M. So here first one is going to be aortic area. So aortic area will be second intercostal space, where we just saw aortic stenosis. Then we have pulmonic area. All the other ones are left side aorta. वैसे तो you're going to remember only one thing on the right side is going to be aortic area. Okay, वैसे we know aorta will be on the right side, but don't get on the left side, but don't get confused. So aortic area is going to be your right sternum, second intercostal space. Then you have pulmonic area, which is going to be left of sternum, again second intercostal space. Then you have Erb's point, which is again left of sternum, and this is going to be 3. So we know APET, but just in case you forget, E, you can just twist, it becomes 3. So 3 comes in between. So that is your third intercostal space. Aorta and pulmonary, right? In the heart as well, you are having aorta and pulmonary together. So aorta is right second, pulmonary is left second. Intercostal spaces, Erb's point will become third. Then you have tricuspid area, which is fourth intercostal space. So it is 2, 3, 4. And then what we have is 5. Fifth intercostal space is mitral valve, okay, which is fifth intercostal space, and mid clavicular line as well. Okay, this is done. Let's quickly move on. So where were we? We were studying about the as. So that is right second intercostal space, and that radiates to carotids associated with pulsus parvus et tardus. So don't get confused. In the aorta as well, you can, in the carotids itself, you can see aortic stenosis. So aortic stenosis is radiating to carotids. It is associated with pulsus parvus et tardus. And the smallest is parvovirus, right? The DNA, the smallest DNA virus. So that, why it's called smallest. Parvo is smallest. So here pulsus parvus et tardus. Now it will make sense as well. Aortic stenosis, it is steno, so very less blood comes out. So that is why you are having pulsus parvus et tardus. Slow and weak pulse you will have, because less stroke volume will be, basically you will have less stroke volume, and that's why you're having pulsus parvus et tardus, and this is parvus means it is slow. Okay, so remember. Okay, moving on. Next you're having mitral regurgitation. So when I write mitral regurgitation, it looks like Mr. MR, right? So Mr. you will remember like a man, Mr. And this person is not good. He is the turkey type. So what he is doing is, he's just sitting on he's that person, vela, not doing anything, sitting on his bike, and he's whistling, blowing whistles at everyone passing by. So and he's not going to spare anyone. He's going to blow whistle to all the women passing by. So it is going to be holosystolic blowing murmur. Okay, best at the apex, and he's turkey. So it just remember something like that, radiating to axilla. Makes sense, right? So something not very hygienic place. So Mr. you're going to remember holosystolic murmur, best is at the apex and radiates to the axilla. So A and A here. Next is going to be mitral valve prolapse. Mitral valve prolapse is going to be a mid to late systolic click. This sounds like MVP mall. Okay, just remember it like that. MVP sounds like some MVP mall, and mall starts late. They don't start early. So that's how we're going to remember. This is going to be mid to late systolic, and malls mein everything clicks, right? You buy everything and whatever you put, it clicks. That's how you're going to remember. It's a click. MVP mall, remember, mid to late systolic, click followed by a murmur. Okay, click followed by a murmur. So murmur increases with decrease in preload. We'll see this later. MVP mall, just remember. There are exceptions to the murmurs. I'll just teach that later, but just remember MVP mall, click followed by a murmur. Late, this is going to be what? Mid to late systolic, click followed by murmur. Okay, next you have tricuspid regurgitation. Tricuspid is nothing but a sibling of TR, MR, the same thing. So you will have the holosystolic murmur, which increases with inspiration. So this is heard at left sternal border, like we just saw, right? It is lower left sternal border. You're going to see this tricuspid regurgitation, holosystolic murmur, same like MR. All right, next. And also, during inspiration, what happens? The blood increases, and that is why the murmur also increases, and that is called Carvalho's sign. All right, next, moving on, you have VSD. VSD is going to be ventricular septal defect. This also will be harsh holosystolic murmur. You literally have a septum in between your ventricle. That's really harsh, right? So remember, you have a pura septal defect in between. So with that will remember, it's going to be harsh. And when you have a septum, it's not like septum is going to close and open. It's going to be holosystolic. So holosystolic murmur it will be, and it is loudest at your left sternal border. Okay, VSD is also, like, all the murmurs are anyway left. This is the only one which is right. So remember, VSD is also left sternal border. Done with your systolic murmurs. Moving on to the diastolic murmurs. We know in diastolic murmurs, here filling is from above. So here you will have the atrioventricle valve. The mitral and tricuspid valve will be steno. So here mitral stenosis and aortic regurgitation will be learning. So let's see, like we have Mr., we also have a Miss, that is going to be mitral stenosis. So here this Miss is little hyper. She is angry. All right. So that is why she is just snapping at her partner. So this is going to be opening snap. She has snapped. Okay, snap, and then you have a murmur. So this is a low pitched diastolic rumble. Best, when someone is pissed, what do? You rumble. She's just rumbling in herself. She's not telling it out loudly, but she's like snapping. She's not using a word, she's using her hand. So opening snap followed by she's rumbling, low pitched diastolic rumble, which is best at left lateral position. Okay, basically you know why she is in the left lateral position. She doesn't want to talk, so she is in the left lateral position. So that is how we're going to learn everything about mitral stenosis. Next, you're having aortic regurgitation. Aortic regurgitation is going to be early diastolic, right? So this is aortic regurgitation. When you write, it is AR. It sounds like array. So array, jaldi aa gaya. Early diastolic. And why array kam ho raha hai? See, it's array, it's decreasing. So it is decrescendo murmur, it's array, bounding pulse, wide pulse pressure, and this is also at the left only, at left sternal border. So aortic regurgitation is also at the left sternal border. Also remember, this is heard at the Erb's point, so that is why it is left, right? So if you remember, the aortic stenosis as was on the right side, right? We remember it on the right side because it is also radiating to the carotids on the right side. Pulses parvus et tardas, we remember it like that, right? So just so that we don't get confused, remember as is ras. Okay, ras. So with that we'll remember it is right side, but also the aortic area is on the right side. But this one is like, we remember it like array, right? Array, decrescendo, array, not left side, right side, and array se Erb's point it is. Okay, decrescendo murmur on the left side. Mitral stenosis is also on the left side only. So here we know the mid clavicular line at the fifth intercostal space. This is low pitched rumbling murmur. Opening snap will be there, which is followed by a murmur. So this is also done the diastolic. Now how to remember continuous murmur? Continuous murmur you will remember as PDA, public display of affection. It is going to be, if you are really truly in love with someone, you're not going to show your love in bits and pieces. It's going to be continuous. With that we'll remember continuous murmur is PDA, but we also know the concept. We know that It is from the aorta to pulmonary artery, and we know the pressure will always be high in aorta. That is why it is continuous. So continuous machine like murmur, which is again best at the left infraclavicular area. Okay. Also, you know, clavicle is also called as a beauty bone, right? And then we are talking about this PDA. So with that we'll remember public display of affection and beauty bone, it goes together. So remember it's left infraclavicular area. So these were your cheat codes to remember. We also know the concept. Now that we have done, let's do a very quick revision. You know, in my session I will make sure that you not just learn, but not just, you know things, get familiar, but also kind of learn by the end of the session. Make sure you do that. So let's see, first thing is going to be systolic murmur, and we know we have to see in the direction. So in the direction we are considering left ventricle, so it will be stenosis, so that will be aortic stenosis. Then what will be the opposite? Mitral regurgitation, mitral valve prolapse. And also one more thing is, along with mitral, remember the tricuspid regurgitation, and also continuous harsh wala, the VSD as well, right? So systolic murmur. So obviously when you have more pressure, the blood will go from this left to right, so that is VSD. So aortic stenosis, we remember it as, and as we know it is going to be crescendo decrescendo. It will be on the right second intercostal space. It is radiating to the carotids, and I can already see aortid here. So carotids mein aortic दिख रहा है, तो that is aortic stenosis. And pulsus parvus et tardus. Parvus we know, paro is very slow. You remember, you know that song in Devdas is, she keeps, I don't remember, but she keeps running to the gate. So it's this show it in a very slow-mo manner. So remember, parvus means very weak and slow, small essay. So small basically, like the parvo, you have the virus as well, the single standard DNA virus, right? Alright, the only single standard DNA virus. Moving on to the medicine. So you are having the pulsus parvus et tardus. Mitral regurgitation, we remember like Mr. With Mr. we remember he is holosystolic blowing murmur, like the turkey Mr. holosystolic, not leaving anyone. Best at the apex axilla, so radiates to the axilla. Next you have mitral valve prolapse. MVP mall, we remember mall late khulta hai, from afternoon to evening, and night late. So with the click and anything you put in the mall, it can click. With that we remember mitral mid to late systolic click followed by murmur, and this we're going to learn it later, the exceptions and everything. Tricuspid regurgitation will be, again it's the same thing, holosystolic. This is a sibling of Mr. So same thing, holosystolic murmur increases with inspiration. So this is Carvalho's sign. Carvalho's sign, remember CT, Carvalho's sign you see in the tricuspid regurgitation, which is with inspiration blood will be in more, and that is why it increases. It is heard best at the left lower left sternal border. So here you are having tricuspid area, which is PET, remember 2, 3, 4. Alright, next you have VSD. VSD is harsh holosystolic murmur, loudest at the left sternal border. Next you have aortic regurgitation. How did we remember diastolic murmurs? Obviously diastolic murmurs, this will be of getting filled, so it will be stenosis of this valve, that is mitral stenosis, and regurgitation of this valve, that will be aortic regurgitation. And we remember it's going to be it's decreasing, it's decrescendo manner. It's not on the left, whereas aortic stenosis was on the, it's not on the right, whereas aortic stenosis was on the right. So this will be on the left, right? Left sternal border. And we remember ray is Erb's point. Mitral stenosis is this miss who is very angry, rumbling, but after a snap. So she has given a snap, opening snap followed by a murmur, low pitched diastolic rumble, best at apex in left lateral position. Next is going to be continuous murmur, which is going to be patent ductus arteriosus. Continuous machine like murmur, which is left infraclavicular bone. That's how we're going to remember PDA, continuous murmur. Next, let's see a few special named murmurs. We have having grandpa. How we're going to remember is there's a grandfather. So we're going to remember grand instead of father, grandpa. His name is Austin, and he's carrying a child, okay? That's how we're going to remember. Wait. Alright, so we're going to remember this grandpa with this picture. So this is going to be a grandpa, and with grandpa we'll remember Graham Steele murmur is seen in pulmonary regurgitation. Now you might get confused whether it is seen in pulmonary regurgitation or stenosis. So for that you can just remember it is grandpa, right? So it is regurgitation. All right, so this is due to why pa is again pulmonary arterial hypertension, so this is due to grandpa. That's how we're going to remember. So his name is Austin, so remember Austin Flint is another special named murmur. And no offense, but see, this all these are diastolic murmurs, and you know, like grandfathers, eventually every one of us are going to die, but grandfathers are also going to die, so we're going to remember it's mid diastolic murmur, which is at the apex. And this is Austin, with Austin will remember AR, this is also R. Okay, Austin is going to be aortic regurgitation. Next you're having Cary-Coombs. Cary-Coombs is mid diastolic short murmur, and we know Cary-Coombs is seen in the rheumatic fever, so this is seen in the rheumatic fever. And that's it about the special named murmurs. And let's see the questions. Oh, before that, let's just see this as well, the preload and afterload. Now we know the concept. Whenever there is preload decreasing, and when does it decrease? Whenever you're standing, it will decrease. When you do Valsalva, it will decrease, right? So whenever your preload is decreasing, your heart will have less blood and turbulence will become less. So most of the murmurs are like that, where preload decreases, murmur decreases. Now what are the exceptions? Remember just the exceptions, HOCM and MVP, where they are increasing. All right, the same thing, if preload is increasing, you're going to have the murmurs increasing. The exceptions are going to be HOCM and MVP. But in the exam we might get confused, you know, we can get confused as silly as like what is after A, B, C. You'll be like, is it D or E? You know, your brain doesn't really work in the exam at all. So for us to not get confused, let's learn what are they going to ask you in the exam. They're going to ask you exceptions, so let's learn the exceptions. So whenever you're standing, it's tall, right? It increases. So in standing it will increase, and you will do Valsalva with the mouth. So Valsalva is like above, right? It increases, upar hai, so it increases. So HOCM and MVP increases with standing and with Valsalva, where all the normal murmurs, they decrease, because in Valsalva and standing the heart has less blood filled. All right, turbulence will be less. Now coming to the preload. Preload, now what is it? Squatting and passive leg rise. Why do you raise your legs? You raise your leg, right? Because to increase the preload, to increase the venous return, we do that whenever someone is unconscious. So we're going to increase the preload whenever we do squatting and leg raise. But just in case we forget in the exam, you know, this is a very, I don't know how to draw squatting. Oh, I don't know, just bear with it, guys. This is okay, just in you're squatting here. So squatting is where you're sitting, right? And legs are also niche, leg is also like down, so it is decrease. So basically whenever there's passive leg rise or whenever there's squatting, in the exceptional cases HOCM and MVP, it decreases. Now remember, these things that you have learned for exceptions, because in exam they will ask you exceptions. Now don't put this logic to the normal murmurs and don't make a mistake. Okay, so preload decreases, which means you will have less turbulence because less blood. But exceptions HOCM and MVP, and we have learned a cheat code as well. You're standing, it will increase. Your mouth is also above where legs are below, so that's why passive leg raise. And squatting, you sit, it is going to decrease, whereas in general it should increase, because when you raise your leg and when you squat, your venous return increases. That is about preload. Okay, coming to the afterload. Now afterload, you remember, decreases. Afterload decreases. A is a smaller, right? Amyl nitrite. So amyl nitrite, afterload decreases. So you are having, whenever you have afterload decrease, it is the resistance. If you have low resistance, you will have low turbulence, right? So be it blood or resistance, when it is less murmurs will decrease. So most of the murmurs are decreasing. The exceptions are going to be HOCM, MVP and AS. Alright, next you have afterload increases in the hand grip, because when you grip, do something, resistance will increase, turbulence will increase, most of the murmurs will increase. Exceptions are going to be aortic stenosis and HOCM, where it will instead of increasing, it will decrease. Since we have learnt only exceptions, I will tell you to learn here as well exceptions only, that a mile nitrite is a big mile. So this is going to increase your murmur here. Alright, in the exceptions, we have, again remember, we are learning only the exceptions. And in the exceptions, your hand grip is, again when you stand, like hand grip, you're doing it down. So okay, Oh, just remember this will become opposite. Hand grip is exception, it decreases, but common sense, you need to hand grip, obviously your resistance is increasing. If your resistance is increasing, turbulence should increase. Whichever is more convenient, remember that. Next is going to be your inspiration. So more inspiration means what? Venous return will be more venous return, so your right sided murmurs will increase, more blood, so tricuspid and pulmonary murmurs will increase. That is what we have seen in the tricuspid regurgitation as well, the Carvalho's sign, right? So that is what we'll remember, that is inspiration. Let's see the FMG PYQs that came in the recent FMG exam. These are your FMG Jan 2025. okay, let's see. We just saw where was Graham Steele murmur heard in. Where was it heard in? We just saw, right? Grandpa, remember? And to not get confused, I also said GR. Look at the R, so that will be pulmonary regurgitation. All right, so we just saw, right? Where is it? Grandpa, pulmonary regurgitation, so that we don't get confused. That was one question. The next one is 60-year-old. This is a 60-year-old with a known case of rheumatic heart disease, presence with SOB, and here hyperdynamic precordium is noted with a water hammer pulse. We remember this, right? Water hammer bounding pulse, basically. So where do you see this? They're also telling it is a pansystolic murmur, and auscultation shows pansystolic murmur and early diastolic murmur. So think of the diastolic murmurs. What do we have? We have two diastolic murmurs. One is going to be the mitral stenosis, the other one is aortic regurgitation. So this is basically your aortic regurgitation, that is array, remember? Bounding, this is your water bounding pulse. So basically remember, water has, it is aortic regurgitation, water bounding pulse. Okay, it is the early diastolic murmur. So can you see this? That's collapsing bounding pulse. Collapsing pulse is the same thing. So here when they said, remember they have said here precordium with a water hammer pulse, that's nothing but your aortic regurgitation, and we're going to remember AR, aortic regurgitation. Next is a patient present with progressive increase in shortness of breath. On examination, left parasternal heave is noted. On auscultation, a systolic murmur is heard. Now what is this? So they are saying, one thing is it is systolic murmur, so it has to be, if you just use your common sense, this has to be here, some stenosis, aortic stenosis or pulmonary stenosis. And then they said it is on the left side, and I know, right? So right side was aortic stenosis, was right. Remember RAS, I just told you to remember. So left side will become pulmonary stenosis, so this will be D is the answer. Okay, the next one is going to be your heart sound. So there was a question on this as well, so I thought I'll just teach this also. So very quickly moving on, we know S1 to S2 is systole. From S2 to S1 again is a diastole, and systole is nothing but, when I say systole, it is basically of filling in water, blood in the ventricles, right? So after the closure of this valve, that is a atrioventricular valve closure, whenever it will close, you will have S1, that is systole will start. I told the reverse, I'm sorry. So basically systole is like you're pumping out the blood, and then when you're pumping out the blood, this has to close, the upper door has to close, right? So that this is a closed chamber, and now you can pump out the blood by opening these valves here. So that is why this, whenever there is a closure of these valves in the systole begins, right? So AV valve closure is S1, systole begins, and then you have this semilunar valve closes, these valve closes so that you can fill in the blood. So that is your diastole. So this is diastole and this is systole. I'm really sorry for the confusion. So this is systole and diastole. So you have the AV valve closure here, you have the semilunar valve closure, that is S2, and then you have the S1 AV valve closure, in between you have diastole and you have systole. Now how to remember this? So in between S1 and S2 you have a ejection click. We know the systolic murmurs, are going to be stenosis. So remember, as is ejection click. Okay, he was remember the as thing, this crescendo decrescendo, right? And we have a turkey mister also, which we will just remember the story like the mister was clicking pics of the as. So remember the ejection click of the aortic stenosis. The one more thing, you have the mid systolic click, which is going to be the MVP, and we remember this as mid systolic because it doesn't start early. And click, we remember like anything you put for sale, it will click. So it was mid, and then there was a click followed by a mid to late systolic murmur. So that is MVP. So you have a mid systolic click and you have a mid systolic ejection click and a mid systolic click, which is MVP. All right, next you are having diastole. Now diastole, you remember it starts with man, you're gonna die because she is angry, MS, opening snap. So opening snap, and then remember the story only, she's going to snap at you, she's going to hit you, and then a sound will come, your head is gonna hit with something, and then plop sound is plop, mid diastolic plop. And where do you see plop? You see in the tumor plop, LA myxoma, right? Mid systolic plop, LA plop. After that you have S3 and S4. What is S3? 3 is physiological, high volume states, pregnancy, thyrotoxicosis, and 3 letters, congestive heart failure. You will see physiological, it is S3 you will see. Whereas S4 is atrial stiffening. Now this is always pathological. Big number is always pathological. Remember, atrial stiffening it is. And 3, you're going to always remember this as well. So when I write 4, it looks like A, right? So this is because of the atrial stiffening, whereas 3 is going to be called as ventricular gallop. All right. So, and then you have the S1 AV valve closure. All right, so let's just see, we saw S3 and S4. Now what is S3? It is early S3. 3, you know, always flip it, it becomes E. So this is early diastole, and 4 is going to be late diastole, just before the S1 it will come. This is due to passive rapid filling. Rapid filling ventricular filling के वजह से होता है. So basically what is happening here, you already have volume overload, right? In the ventricle you already have volume overload, and when you have passive rapidly it gets filled, this ventricular wall will vibrate. So that is your 3. 3 is V. Okay, 3 is V, that is ventricular filling, passive ventricular filling, ventricular wall vibrates. So this you're going to see 3 is physiological, you will see in the congestive heart failure, pregnancy, and high output states, and this can be normal as well. Whereas look at this one, late diastolic hai, it is active atrial contraction into stiff ventricle. So this is due to atrial contraction, stiff ventricle resist, and atria will vibrate. So we remember 4 is because of the atria, right? Oh, anyways, okay, 4 is because of the atria, and we're going to remember the stiff ventricle vibrates. This is seen in the aortic stenosis, HOCM, LVH. So this is always and always pathological. So atria, the ventricle is stiff here. So can you, hypertrophic cardiomyopathy, ventricle will be stiff when it is LVH, the left ventricular hypertrophy, and also when it is stenosed, it will aortic stenosis, it will be stiff. So remember, this is always pathological. All right, moving on. This was the question. A patient has been diagnosed with mitral stenosis, and what is the determinant of the severity of the mitral stenosis? Opening snap. So that tells this opening snap, right? It tells the gap between the S2 and the opening snap. See, between the S2 and opening snap, if the gap is less, it is more severe. It is like that. So this is the answer, S2 and opening snap. Look at this one. The more severe the thickening, if the thickening is very severe, opening snap occurs in diastole. That is why opening snap is occurring. So whenever you have decreased intervals between S2 and opening snap, it means that the stenosis is severe. So that is the answer. So auscultatory findings, increased severity when you have decreased interval between S2 or A2 and the opening snap, and increased duration of the diastolic murmur. So if you have the decreased space here, that's going to be your opening snap. So that is what is happening, right? After this closes, what happens is your for the ventricles to get filled, this valve should open, the aortoventricle, basically the mitral valve should open, and it is stenosed now. So when a stenosed valve will open, you will have opening snap, and its severity will tell you the decreased interval, the more severe it is. And why it is now let's see what the concept here is. So basically here what is happening, you are having an opening snap, which means the left side, it is stenosed, right? So now if I'm telling the stenosis is more, it will take time for the left atria to put pressure and open it, right? So if you're having more stenosis, then what will happen? The LA pressure will become even more. So when the pressure is more, it will obviously open it faster. So the more stenosis, pressure will become more. When more pressure, it will open faster. This is the concept, but just remember, the जितना जल्दी वो गुस्सा होती है उतना सिवियर वो है, राइट? द टॉपिक मस्ट बी सिवियर. नाउ दिस इज गोइंग टू बी योर cheat code. We remember MS is miss and she's snapping at you, and the faster she's snapping at you, which means you're more in danger. So that you know the concept now. You also know a cheat code. Whatever you remember in the exam, what matters is the right answer, right? Anyways, the next with this I'm gonna end the last topic here. This was also a previous Jan. All these are FMG Jan 25 previous questions. So this one is again a very good concept. So we will have a concept and a cheat code here as well. For this we'll have to learn the concept first, okay? Then it will become very easy. So this is your blood vessel, and this is where you have collection of fluid, ascites is happening, right? So and this is, just remember, this is your abdomen. I'll just draw another color. So this is going to be your abdomen, and this is your blood vessel, and you have fluid basically being collected here, and that is going to be your ascites, right? So here what is happening is, what is SAAG? That tells you serum albumin, ascites, serum and ascites का albumin gradient is what you're seeing basically. So we are seeing the albumin in the serum का albumin, and also the albumin in the ascitic fluid. So this is what we are seeing. The difference is the gradient is SAAG, right? So we are subtracting these both. Serum, again I'm writing serum's albumin minus the ascitic fluid's albumin, and this is the gradient that we are seeing. So here what is happening is, imagine this is going to be 10 and the albumin gradient is 5. Now this is another case where this is 10 and the albumin gradient is 2. So here it's gonna be 5, here it's gonna be, I'll take another color. So here can you see, when I see this, the albumin here is less, which means fluid is being accumulated, right? Albumin is not leaking, but fluid is leaking. Albumin come here, that's why the gradient is low, high. 8 it is, right? That's why the gradient is high. Wow. Next you are having the serum albumin is 10 and the ascitic albumin is 5. Here the gradient is low. When the gradient is low, it tells me that albumin is also leaking, which means protein is also, albumin is also leaking. Understood? And we know when it is transudate, when do we say it's transudate? When it is fluid. And when the protein is leaking, we say exudate. So when the gradient is high, it is transudate. When the gradient is low, it is called exudate. Which means, just remember, even if you don't remember the everything, the concept in the exam, just remember we are seeing the serum albumin and the ascitic fluid albumin's gradient. Now the gradient is higher or lower, and we know water gushes, right? Water, when you think of water and proteins, just imagine leaking. Here anyway fluid is leaking. Along with that, if you have more albumin leaking, that's what called as exudate. You will have high lower gradient SAAG, and when you have lot of fluid leaking, it is called transudate, and you will have higher gradient, right? So how we going to remember? High is hydro, so higher gradient, we remember high say hydro, matlab here it's going to be transudate. Here a lot of fluid is being leaked and less albumin. And when I say exudate, इसका opposite हो जाएगा, low gradient, which means you have albumin leaking, which is exudate. This is your concept. I have also told you a cheat code. So look at this one. When I say the gradient is low, what did we remember? This must be your exudate. When I say the gradient is high, it must be your transudate, right? Transudate it will be. So something to do with fluid. So this will all be your portal hypertension wale causes. This will be your non-portal hypertension wale causes. So with that it's all sorted. Whenever it is high gradient, high se we remember hydro se we remember transudent, which means fluid is being leaked. And I know whenever I say it is low means it's opposite ho gaya, exudate and non-portal things. So here basically there is leak of, so basically when I say low, there is leak of albumin. So leak, we will remember biliary leak. Nephrotic syndrome, you have albumin leaking, makes sense, right? Exudate se sara E se infections and inflammation comes. So pancreatitis, infection, remember E se infection. Exudate, remember E is gonna be your all the E wale causes. E infection, we'll remember this as E infection. We remember this as E inflammation. So this is gonna be your pancreatitis, biliary leak and nephrotic syndrome, because your albumin is leaking. Pancreatitis, tuberculosis, carcinomatosis, all these infections and inflammations is going to be exudate where it is low gradient. And when the gradient is high, hydro, water, we remember portal hypertension causes. In this we are going to see ascitic protein less than 2.5 or ascitic protein is more than 2.5. Here it is, yes, definitely it's not like there is no albumin leaking at all, but if the albumin ascitic protein is very less, it means liver is the problem here. Liver is not producing. So cirrhosis, late Bucchiari syndrome, massive liver. See, all the liver wale causes will be there. Bucchiari syndrome and liver metastasis. When the ascitic is more than or equal to 2.5, so here you have other causes like hypertensive causes like congestive heart failure. Like if you have heart failure, back pressure, portal hypertension, congestive pericarditis as well. Then you are having early Bucchiari syndrome, okay, IVC obstruction ho gaya, sinusoidal obstruction syndrome, all these comes here, okay. So remember here it is so late, here it is late, so itna late ki now liver is not producing, it is less than 2.5, here it will be more than 2.5, congestive heart failure, congestive pericarditis, early Bucchiari syndrome, IV obstruction, sinusoidal obstruction syndrome. That's it. Then what is the question here? We'll revise after that once more and we'll end this session. Patient with liver cirrhosis present with breathing difficulty due to massive ascites. So here ascites is massive and they are telling it's the liver disease. And we know if it was infection, inflammation and nephrotic syndrome where albumin was leaking, it would have been what? Low, less, na? It would have been less, because again we can just remember it like this, otherwise I'll just write it. It would have been less में we will have chalo, I'll not confuse you with that, let's not just let it be there. Basically when we have more protein, when you have more albumin leaking, it is exudate, but here it is liver and exudate hota, to it would have, the ratio would have been, the gradient would have been less, but high gradient is hydro we know is all portal hypertensive causes. Usme bhi we have to see if it's liver cirrhosis, it will definitely be more or less. It will be less, right, because your liver is not performing well here, so it would have been less than 2.5. And what is the question they are asking? Incorrect. Because they are asking incorrect, now the answer will become B. Because it is liver, hydro should have been high, this is correct. Because it is liver, which means liver is not producing albumin, it should have been low, less than 2.5, this should have been correct. And this is occurs due to secondary hyperaldosteronism, this is also correct. So basically this is wrong, less than 1.1 is wrong, it will be exudate here, right? So that is why. You didn't even have to know this last option, you just know the concept. And by the way, in the question, whenever these contradicting this options come, it has to be between these both, and we know it is incorrect, so we have selected the second one. Let's just quickly revise what we have seen. Okay. Whenever you see SAAG, it is basically albumin gradient between the serum and the albumin. Now the cheat code is wherever it is high, it is transudate, wherever it is low, it is exudate. But I also know the concept. When serum minus albumin, it is high, it means lot of fluid is coming out in the ascites, right? So basically in the albumin, the albumin in the ascitic gradient is less, that is why your gradient is high. And whenever it is less, serum ascitic albumin gradient is less, I know albumin is leaking, that is why your gradient is low. But never mind, even if you don't remember the concept in the exam, we know H for high, H for hydro, water is transudate, low will become exudate. And we know if the ascitic is less than 2.5, liver is not working, so cirrhosis, late Bucchiari syndrome, more damage and ascitic protein, it's not working, massive liver metastasis. When it is more than 2.5, it is all portal hypertensive causes like congestive heart failure, early Bucchiari syndrome, IVC obstruction, sinusoidal obstruction syndrome. And less than 1.1, it is infection, exudate, infection, inflammation and leaks and everything, biliary leak, nephrotic syndrome where albumin is leaking, pancreatitis, inflammation, carcinomatosis, peritoneal carcinomatosis, not the liver mets. Whenever it's liver, we know it has to be the transudate more than 1.1 will be the gradient, and the infection, one more infection would be tuberculosis, and that's it. I'm going to end it here. So success doesn't come from what you do occasionally, it comes from what you re-revise consistently, and that's what I'm talking about. So what I'm planning is, this is going to be a subscription based program that I'm planning, and if you are interested, you can join my channel, and if there are more people who want to enroll, we can figure out something. I was planning something like we can do an alternate class, we'll have a poll, and accordingly we will decide how to go about because revision is very important. You can just follow your own schedule, whatever your simultaneous schedule, just give me 2 to 2.5 hours of time, because we might not revisit stuff, and I will make whatever important the high yield topics, the PYQs, along with covering the PYTs, along with PYQs. So it will be my responsibility to make sure that you have not just covered PYQs but also PYTs along with it, and we'll have a schedule where we are following it alternate days. So one day if I have a class, you have to revise that for sure the next day, and the PDF will be shared in the group. So we'll plan it accordingly. So if you're interested, do join the link below. I'll post it, the Telegram channel link, and this will start in the mid-August. So once everyone's enrolled, I will share the plan and everything will go accordingly. And yes, do subscribe and let me know in the comments below if you have enjoyed the session. All the best. Keep revising.